Hello, I'm Mary Sebelik, and welcome to the panel on surgical cancer care and global health. I'd like to give you a very brief overview of what we'll be doing with this panel. I'm going to talk a little bit about global burden of cancer internationally and introduce the panelists to you, who are an illustrious group of specialists who will be talking about guideline development for cancer care in developing countries, creation of advanced training at a fellowship level, and the creation of global virtual meetings for tumor discussions in the era of COVID-19. After the panelists speak, we'll have a brief time to have live questions to the panelists and then wrap up. And I'll move right into a very brief discussion about what our current global demand for cancer surgery is. So this, I'll start this out with an illustration of a keynote speech that was given at the American Head and Neck Society by Dr. Mark Schreim, who is the O'Brien Chair of Global Surgery at the Royal College of Surgeons in Ireland. And he gave an amazing and very poignant talk about a patient of his who had a very deforming head and neck tumor, who actually sold his land and walked many miles to the Mercy ship where Dr. Schreim was working to have this tumor treated. So the tumor was able to be successfully removed, but the man lost his land and his livelihood just to get surgical care. This is heartbreaking. And in fact, just last month in Lancet Oncology, this paper was published, which is a population-based modeling study, which demonstrated, sadly, that our current surgical workforce would need to increase over 300% to meet current needs, and our anesthesia workforce would need to increase over 550% to meet current needs, without regard to what we need in the future. Put another way, this paper talks about the number of patients who need cancer surgery per surgeon. And the contrast is that in Europe, there are 7.3 patients needing cancer surgery per surgeon. In African countries, that's 80. There are 10 times more patients needing surgery per surgeon in low-income countries. So this is another patient I'd like to use to describe some of the barriers. This is a patient I met who walked to clinic for many miles through a rural setting, and he had this sore on his lip that kept getting bigger and more painful. The barriers to his care is he couldn't even get a biopsy. He didn't have money, nor was he geographically close to somebody who could send this to a pathologist. He also didn't have access to any other kind of care for this. And ironically, he couldn't work because of this tumor, and so he had even less money. So I performed an excision, a reconstruction, and removal of adjacent nodes, because I knew we probably didn't have any other means of treating this. And 2 years later, he is cancer-free and doing well. Another illustration of some of the barriers to care is this gentleman who developed a tumor in his larynx and actually was able to present to a teaching hospital where the residents were able to perform a tracheotomy so he could breathe. But then it stopped right there. There was radiation at this facility, but it was so booked for many months he couldn't get started. And there was not an attending surgeon who could take the residents through the surgery to get a laryngectomy. So he was then able to get a surgery when I was able to help out. And that was great, except at this facility, there were no speech therapists to help the gentleman learn how to communicate again. So to study these kinds of deficits in ENT care in Africa, Dr. Fagan, one of our panelists, did a brilliant survey in 2019, followed by the same survey in 2015, and discovered that disappointingly, there was very little progress between those two periods of time, and specifically with laryngectomy care, speech rehabilitation, and radiation services, there was very little improvement. He posed some solutions to this, including both augmenting and increasing numbers of training centers in Sub-Saharan Africa, improving infrastructure, and especially collaborating with people from high-income countries and with NGOs. But collaboration historically has taken the form of surgical short-term missions. And we may all have heard stories where a surgeon comes home to the United States and says, wow, I did all these great surgeries. In 3 days, I got 60 surgeries done. Well, that doesn't build capacity and it's not good patient care. So Dr. Fagan and his co-authors published a list of rules of engagement. And one of the most important rules, it is inappropriate to count your success or outcomes by how many surgeries you could perform. And in fact, your outcomes should be measured by what you can transmit to your hosts based on what your hosts need, including resource appropriate equipment, research capacity building, increasing training opportunities. These are all the things that can produce capacity building and should be the measure of outreach. One of the ways we can collaborate is through our professional societies, and our American Academy of Otolaryngology does foster educational collaboration between it and sister societies like the African Head and Neck Society. And in fact, through these professional society collaborations, we are all can be global leaders to help this problem. My references, and that takes me to the introduction of our first panelist. Dr. Johan Fagan is the Leon Goldman Professor and Chairman of the Division of Otolaryngology at the University of Cape Town in Cape Town, South Africa. He is the recipient of the Nikhil Bhatt International Service Award from the American Academy of Otolaryngology, and in fact is the first African to have received this in 2019. He established the Karl Storz Advanced Fellowship for Head and Neck Cancer Training, partly supported by industry, but mostly supported by the University of Cape Town. He established, co-authors, and edits the open access atlas of otolaryngology surgical care. And he is the co-founder and first president of the African Head and Neck Society, and he is currently very actively developing cancer care guidelines for developing countries. This is Groote Schuur Hospital at University of Cape Town, and this is his beautiful front porch on which a large group of international head and neck surgeons gathered to discuss treatment guidelines. Our next speaker, equally illustrious, is Dr. Wayne Koch, who is a professor of otolaryngology head and neck surgery at Johns Hopkins. He is an international leader in head and neck surgery and education, and past president of the American Head and Neck Society. He received the Distinguished Award for Humanitarian Service from the American Academy of Otolaryngology in 2016, and he established another head and neck fellowship at Mbingo Baptist Hospital in Cameroon. This is the Baptist Hospital that he works at, and this is a beautiful photograph of him imparting his knowledge and surgical skills to his trainees and colleagues. Our third speaker, Dr. Chege Macharia, is a head and neck surgeon from AIC Kijabe Hospital. He's actually a general surgeon who finished his training in 2015 after receiving his medical degree from the University of Nairobi. He then went on to advanced head and neck fellowship training through PACS and through Loma Linda and Johns Hopkins University. And he, in the era of COVID, has developed an amazing virtual tumor board that is widely attended and allows collaboration across the globe for the care of head and neck cancer patients. This is a beautiful photo of an aerial view of AIC at Kijabe Hospital. And this is a screenshot from the tumor conference that he runs. Notice that there are 25 people logged in times 6. So this can attract about 150 people each month for this great experience. And a last picture I'm putting up is this unfortunate patient with a tumor. But I like this picture because it has me, Dr. Macharia, Dr. Fagan, and Dr. Koch all lined up. So without any further delay, I take you on to Dr. Fagan for his presentation. Thank you.
Good day. Thank you very much for the opportunity to share my perspectives on head and neck cancer staging and guidelines for developing countries with you. Head and neck cancer is really a developing world disease. 70% of head and neck cancers occur in developing countries. 80% of head and neck cancer deaths occur in developing countries, yet only 5% of global cancer resources are spent in developing countries. Africa is facing a major public health problem with cancer. It's predicted that between 2010 and 2030, there will be almost 100% increase in both incidence and mortality from cancer. Yet, access to radiotherapy is very poor, despite Africa having more people than Western Europe and North America combined. You'll note that it only has a fraction of the number of radiation therapy machines compared to Western Europe and North America. In fact, only 24 of 52 countries in Africa have radiotherapy facilities. And it's not only Africa. You'll note from this heat map that many countries in the world, the patients have very poor access to radiotherapy facilities. And the same is true for surgery. You'll note that compared to high-income North America, in Sub-Saharan Africa and South Asia, less than 5% and less than 3% of patients, respectively, have access to timely, safe, affordable surgery. And this is reflected in the number of head and neck surgeons in Sub-Saharan Africa. There are only 19 fellowship-trained head and neck surgeons for 1.1 billion people. And if you use the same ratio for the USA, you'd have only 5.7 head and neck surgeons for your entire country. I'd like to discuss briefly the concerns around the UICC, AJCC head and neck cancer staging as it pertains to developing world practice. The UICC and AJCC have quite understandably been introducing more and more non-anatomical factors when it comes to staging cancers in general. And in the head and neck, with oropharyngeal cancer, it's now become mandatory to test patients for P16 status because this correlates very well with outcome. Yet, only 16 of 17 head and neck surgeons in 13 countries in Africa cannot test their patients for P16 status. They've been advised to simply classify all patients as being P16 negative. And so we put out a plea that the AJCC and UICC should retain anatomical staging for low and middle income countries. And if that is not possible, then we will be required to develop our own resource appropriate cancer staging system. I'd like to then move on to international head and neck cancer treatment guidelines and whether these are fit for purpose for developing world practice. I'm going to use thyroid carcinoma and nodule evaluation in the guidelines of the NCCN to illustrate the concerns and what we're doing about it. So if you have a patient with a thyroid carcinoma or nodule, the first thing you would do is a TSH. Now, this might not be available to your patient or affordable to your patient where you're practicing. Then you would move on to an ultrasound or an ultrasound-guided fine needle aspiration cytology. This might not be available. Once again, fine needle aspiration cytology might not be available or reliable. And some patients might require radioiodine imaging, which might not be available. When you're dealing with a suspected papillary carcinoma, you would first do an ultrasound of the thyroid and the neck. You would then proceed perhaps to an ultrasound-guided fine needle aspiration cytology. The minimum procedure would be a lobectomy or a lobectomy with isthmusectomy, and you may have to proceed to a total thyroidectomy. And some patients might require radioactive iodine therapy. Now, international thyroid guidelines therefore assume the availability of special investigations of radioactive iodine therapy and of thyroid and calcium replacement therapy and monitoring. But they do not cater for situations of limited investigations or treatment, as is often the case in developing countries, and managing the sequelae of thyroid lobectomy, bearing in mind that 25% of patients become hypothyroid, and total thyroidectomy, bearing in mind that 1.5 to 5% of patients become hypocalcemic in good centers. So it's true to say that international clinical practice guidelines may be unhelpful, they may be inappropriate, or may even be harmful if simply applied in developing countries because of the unavailability or often the unaffordability of these special investigations of radiation therapy, of surgery, or managing the sequelae of treatment. The African Head and Neck Society was established in 2016 by a group of head and neck surgeons all fellowship trained in Africa. And one of our big projects has been to promulgate clinical practice guidelines for head and neck cancers in developing countries and limited resource settings. And you can access these guidelines on the African Head and Neck Society website. We convened a group of endocrine surgeons and from North America, as well as from Europe and from all over Africa in 2018. And we interrogated and we adapted the guidelines of the NCCN for resource-constrained settings. And you can access these thyroid guidelines on the African Head and Neck Society webpage. An example being the evaluation of the thyroid nodule or mass. There are 16 different management scenarios based on the availability or affordability of ultrasound, TSH, thyroid scan, and fine needle aspiration cytology. When a patient has access to all 4 of these modalities, then you click on number 1, and that will take you to a management algorithm which would be familiar to you in North America. If your patient does not have access to reliable ultrasound, you'll click on number 2, and that takes you a different management algorithm. If your patient does not have access to ultrasound or cytology, you click on number 8, and that takes you to yet a different management algorithm. Now, when you're dealing with a suspected papillary carcinoma, then there are 8 different management scenarios based on the availability or affordability of thyroid monitoring or replacement therapy, calcium monitoring or replacement therapy, or the availability of radioactive iodine therapy. If you have all these available, then you click on number 1, and that takes you to a management algorithm, which is once again should be familiar to what you do in North America. If you have a situation where these modalities are not available or affordable, or a patient is unlikely to present for follow-up, then you click on number 8, and that takes you to a different management algorithm. And you note that we've introduced the concept of a nodulectomy, that's simply taking out the thyroid nodule to preserve thyroid function, and subtotal thyroidectomy to preserve parathyroid function, which are procedures which you would not even contemplate in North America. And we've done the same now for salivary gland tumors, for tumors of the larynx and the hypopharynx and the oral cavity and oropharynx. And we are currently finalizing the guidelines for nasopharyngeal carcinoma and the unknown primary. And these guidelines have actually been very well used in the initial 24 months as we've been adding more and more tumor sites. We've had over 9,000 visitors with 46,000 page views, and I'm very pleased that the majority of them have come from developing countries for which they are intended. So the African Head and Neck Society guidelines for head and neck cancers in developing countries and limited resource settings are, they really tailor care very precisely according to the resources available to the patient and the treatment center. I do believe the Global South is best qualified to write such guidelines because we best understand the challenges, also the constraints, but also the possibilities of practicing under these conditions. And importantly too, the Global South is taking ownership, leadership and responsibility for management of head and neck cancers in developing countries. So I'd like to just reiterate that you can access these guidelines on the African Head and Neck Society website. And I once again thank you for the opportunity for presenting at your meeting today.
Good afternoon. I'm Wayne Koch. I'm here in beautiful Douala, Cameroon. And my assignment for the afternoon is to talk about our head and neck fellowship training program, as well as putting it in context with the program in Cape Town and our hopes to increase fellowship training in other centers in Africa. As you've heard from Dr. Fagan, the need for surgeons is well known to everybody. In many parts of Africa, there are no surgical services available, and there certainly is a decreased, even less amount of subspecialty trained surgeons, such as head and neck surgeons, available. To put this into context, in my hometown of Baltimore, there are almost 3 million people, and Cameroon has about 25 million now. We have about 150 otolaryngologists in Baltimore compared to 35 in Cameroon. Baltimore has 2 medical schools that train residents, and there are many fellowship training programs as well. Cameroon has a single residency training program in Yaoundé and no subspecialty training. So despite the great need, this lack of subspecialty trained surgeons is a real crisis. Programs where people go overseas often don't train for the setting in which they will return, especially in low resource settings where technology needs to be fairly low level so that it's sustainable. In addition, actual surgical training needs to be hands-on at the OR table with the fellow doing the surgery, and that's not available in observerships and other fill-in type fellowship training programs. Once a fellow is trained, there's a high risk of brain drain moving somewhere else where there's better pay. The conditions in most parts of Africa are substandard compared to what we're used to in the US and in Europe. Low pay, no support staff, poor facilities. And so as a result, many well-trained surgeons leave their country after training. The problem for head and neck cancer patients is made worse by the paucity of radiation oncology centers. You see Cameroon has 2 dots in it, but only one of the 2 units for radiation in Cameroon is working, and they treat about 25 patients a day. When Dr. Fagan's program began in Cape Town, there were no subspecialty fellowship trained head and neck surgeons that we know of in Africa. Now there are probably closer to 19 to 20, depending on how you count, including those from Cape Town and from our program in Cameroon. The Cape Town Fellowship is university-based. It's a fairly traditional or standard head and neck fellowship of the sort that you are familiar with in the United States. It is sponsored by Mrs. Stortz and the Carl Stortz Corporation. The fellows that have been trained have all gone back to home country. And here's the first 12 of them and their locations. And this is the bulk of head and neck fellowship trained surgeons now in Sub-Saharan Africa. I work with an organization called the Pan-African Academy of Christian Surgeons. This is a non-governmental, faith-based organization based in the U.S. that trains general surgeons and orthopedic surgeons, and we now have our one head and neck fellowship training program as part of this program. Our fellowship is based on the American Head and Neck Society model, but it is staffed by a rotating group of faculty. We do train the fellows locally in Africa with hands-on surgery where they are actually doing the procedures and learning them. It's funded by donations and we buy equipment and textbooks as well as a stipend. And we do provide a rotation in the United States for medical oncology, radiation oncology, and speech-language pathology as well as pathology. But of course, while the fellow is in the United States, he or she cannot operate, so we limit that to a 1-month experience. The program is set in a hospital about 20 kilometers outside of Bamenda, the capital of the northwest region of Cameroon. We chose that site because it is the place where the PACS program has their general surgery training program, and so we can use many of their resources. But there is a good caseload there, and we have a full-time partner, Dr. Acha, who's an otolaryngologist that is based there. Until recently, this was a stable environment. There have been some political problems in the last several years, but the program has continued, and it's a well-equipped hospital. Here is its location, a 7 or 8 hour drive up from Douala on the coast, and in a lovely part of the country indeed. One of the strengths of this location is that it is administered by the Cameroon Baptist Convention, and the Institute for Training in the Cameroon Baptist Convention has now been recognized by the Cameroonian government as a valid site for training residents. There's local leadership and administration, and as I mentioned, Dr. Acha, an otolaryngologist trained in Kenya, is my full-time partner there. He has trained nurse practitioners who staff 5 or more regional health centers and refer patients to the central hospital for surgery, which helps give us adequate caseload. As I said, I've been the fellowship director. In 2017, we had 12 volunteer faculty members for 2 to 4 week visits. In 2020, because of COVID and the political situation, we had 0. So this program is now on life support, but it is still going. I was just there last week. The fellows are all either general surgeons or otolaryngologists. We pay them a stipend, provide curriculum, textbooks, examinations, and the rotation in the United States. There is a memorandum of understanding between PACS and the Cameroon Baptist Convention. The program is also sponsored through Johns Hopkins, which allows me to use my time and gift account. And Loma Linda University in California provides the academic accreditation for PACS. Here are our 3 graduated fellows. Dr. Chege Macharia, who is on the program today, was our first. He's a general surgeon trained in Kenya at the Kijabe Hospital, and he's returned there. Dr. Masela Bogali is an otolaryngologist trained in Ethiopia and is back actually in Adama in Ethiopia doing head and neck surgery. And Dr. Marco Fanarico has returned to Madagascar where he practices general surgery and head and neck surgery. Here's our current team. Dr. Bonko on the far left is just finished his residency training in Kenya and is interested in rhinology, but also made a head and neck fellowship. Myself, and then Dr. Kiafon Nachur is also a graduate of the program in Kenyatta and is interested in head and neck fellowship. Dr. Steve Kyoto is a general surgeon who's our current fellow, and Dr. Everysis Acha, the otolaryngologist on the faculty. These are the sites where these head and neck fellows have returned from either Cape Town or from our program. I put a blue dot here in the Democratic Republic of Congo because that is where Dr. Kyoto comes from, and he may well go back there in the next few years. COVID has produced challenges. As you all know, travel has been restricted. I've been able to get in and out without any problem. We were there in November and again in just this last week. But the willingness and ability of visiting faculty to participate has been reduced. And since nothing replaces in-person hands-on mentoring, a number of Zoom calls can replace actually doing cases with the fellow. Our current fellow has spent 2 years and has only finished 4 months of his training. So we have worked with Dr. Fagan to produce a proposal that the African Head and Neck Society is in the process of implementing, where there would be flexibility of the length and location of training so that we can utilize away rotations with local mentors or visiting faculty. It's a competency-based metric instead of a time-based goal, and involves achieving competency on a Liford scale in over 20 evaluable procedures and other knowledge-based areas. And there'll be a final examination. The trainee will maintain their operative log at the various sites that they go. The local faculty will evaluate on the basis of these units of training, and the program director will collect and verify all these evaluations and provide an overall evaluation. And then the African Head and Neck Society will examine and approve the fellows when they're finished. We hope to establish such fellowships at various places around Africa with graduates of our programs, including the program now in Cape Town and Cameroon, but also in Ghana, Ethiopia, Kenya, and Senegal. So these are all in process. And hopefully this will be adopted, be successful, and allow for a real increase in the number and the quality of head and neck surgeons in Africa. Thank you.
Hello, everyone. My name is Dr. Chege Macharia. I'm a head and neck surgeon at AIC Kijabe Hospital, which is in Kenya, and I'm also a member of the African Head and Neck Society. Thank you for this awesome opportunity to discuss our experience and just share experiences with you with our monthly virtual tumor board, which is going to be the subject of my talk. So just start by mentioning that a few of the things I might mention today are part of a paper that we've written up and submitted for publishing with two of my colleagues from South Africa. Tessia Den is an ENT resident at Grotowski with Professor Johan Fagan, and he helps to coordinate an ENT virtual meeting that is fairly similar. Tashneem Harris helps to coordinate a cochlear implant meeting, a virtual cochlear implant meeting for the continent of Africa, also fairly similar, and we've written up this paper about it. So by way of introduction, first about the African Head and Neck Society. It's a fairly young society founded in 2016 by the first 14 head and neck surgeons on the continent that had gone through a full year's fellowship training. And these are 14 head and neck surgeons from 11 Sub-Saharan African countries. And since then, the society has expanded in membership and also in activities. And so we've been able to hold annual conferences as well as dissection and ultrasound workshops and so on. The year 2020, we were scheduled to have our annual meeting in Senegal, but as had happened to everyone, COVID happened and that had to be cancelled. The membership of the African Head and Neck Society is quite varied in terms of our backgrounds and resource availability or even or constraints, and this does directly affect how we manage our head and neck cancer patients. And so we felt we needed to come up with a platform where we could discuss this continuously, just as we would at conferences, and exchange ideas, and especially those that would suit our various settings. So the concept that we agreed on was to have monthly meetings, just to make it feasible and not too frequent, and set up meetings that would be interactive, allow for feedback and an easy exchange of ideas, and create a space where even our trainees could present these patients, these cases. The idea would also be to have the usual bread and butter head and neck cases that would then be tackled with various backgrounds in mind, as well as to present any clinical conundrums that we would encounter just for exchange of ideas as well. The information or the links to these meetings would then be shared within our regional networks, as well as the African Head and Neck Society website. We chose to use the Zoom platform just because of its lower bandwidth demand when compared to some of the other options that were available at the time. The format chosen was to have a 1.5 hour meeting each time, divided into 3 sessions of roughly half an hour each. And later on, we also added the idea of having a pre-selected panel for each session, just to allow for these discussions. So far, the progress has been great. We've been able to hold these meetings every second Friday of every month since inception in July of 2020. We've been able to host between 80 and 150 participants, predominantly from Sub-Saharan Africa. But we've been delighted to also host attendees from all over the world, predominantly North America, Europe, and Asia. There has also been very welcome collaborative participation by our American colleagues, formally being part of these meetings and contributing either in person or sometimes even just through the chat function. It's been wonderful. And then we've had CPD points that have been offered by the University of the Free State, which is in South Africa. And just to give a taste of some of the experiences we have, I'm going to share images, and these only happen during one meeting. This is just one meeting where during one of the, must have been the first session, this was presented by our colleagues from South Africa. And they presented this case of this gentleman with a fairly large lower lip tumor that invaded the mandible. And this was resected and then reconstructed with a free flap. Now, that may not be readily available to all head and neck surgeons on the continent. But within the same meeting, our colleagues from Senegal had a fantastic presentation where they presented all sorts of the experiences with all sorts of regional flaps to reconstruct fairly decently large defects, almost similar defects as to what had been presented by the South African colleagues. And so a meeting like this ended up being quite wholesome in terms of what was tackled start to finish. And in this screenshot, again, you see the faces of all who are involved. And of course, notably, Dr. Mary Sebelik is right there. Some of you might know Dr. Mark Zafero, and of course, Professor Maya is there. So, it's just, as well as all my colleagues from all over the continent. So it's such a wonderful mix of everyone being able to come together every month and share ideas and learn and grow. There have been challenges, and I'd say these are the two biggest that we've had to deal with. The first is language barrier. In the previous example that I showed, our Senegalese colleagues are predominantly Francophone. And this specific presentation that they made, they did it in English, but that was not exactly easy for them, though, we accommodate each other and we were able to understand really well. But that can be a challenge. On the continent of Africa, there are English speakers as well as Arabic, Francophone, and Spanish, I think. Internet connectivity on the continent can be a challenge, and especially causing some presentations to be interrupted. I know that is not unique and happens all over, but it has proven to be a bit of a challenge, so that during each meeting we have to be prepared that some presentations may drop midpoint, and we have to wait for them to reconnect while another presentation continues. But of course, we celebrate the small wins. I think for us, it's been very exciting to have a truly international meeting happening at such a frequency and involving so many people that are involved in the management of head and neck cancer patients, especially in Africa. And those who are interested, of course, our trainees, and of course, our mentors and those that have gone ahead of us. And to be able to glean then from the wisdom of such senior and talented minds at such a frequency is also of great value. And in conclusion, what I'd want to say is that we are probably still on a steep portion of the learning curve as far as these virtual education platforms are concerned. I truly believe that there's a lot more that we can glean out of this and benefit on the continent and maybe the whole world. But truly, this has been an excellent and very beneficial experience for us, particularly even for our patients and how it is that they get to be managed, just as we continue to exchange ideas and grow from this kind of meetings. Thank you very much.
Hello to my friends who so generously gave your time and efforts to join this panel. I am overwhelmed, and thank you so much. I have some questions for all of you. My first comment, however, is I always learn how to do things better at home from how my colleagues overseas do things for their patients. So thank you again. Dr. Fagan, I have to address the masterful job that you've taken, the enormous job that you've taken on to point out that all of our fancy cancer treatment guidelines simply do not apply to many settings around the world. And thank you for doing that. That also has great value for middle-income countries as well, or in rural settings in the United States. But can you briefly again describe the process for how you modified those guidelines? Did you use a consensus, surveys? How did you do that? I'm not sure Dr. Fagan is still on. Let's see. If not, I'm changing my next question to Dr. Macharia. I'm so curious about how, on the ground, what are some of the best things you have at AIC Kijabe for your head and neck cancer patients? What are some of your best assets?
Thank you for this opportunity. I'd say Kijabe has been a site of training of both surgeons and anesthetists. So we're able to have fairly high standards as far as surgical services are concerned. Right now as well, I work with a colleague. He is an expat from the US. His name is Dr. David Nolan. He is an otolaryngologist that's also done a fellowship in facial plastic surgery. So for our patients in Kijabe, we're privileged that we're able to offer fairly timely, decent surgeries as well as reconstructive options where possible. But that may not be the same for all my colleagues. But yeah, it's been a pleasure to work here. Yeah, and those are our assets. Thanks.
What are some of the challenges? What would you like to see? What deficits would you like to see fixed at Kijabe?
Well, actually, it's even a bit more global than Kijabe, and I think what has been pointed out earlier is elucidates it quite well. We are definitely struggling to keep up with the numbers. The number of patients that need urgent surgeries, especially cancer surgeries, are quite big, and yeah, just for the two of us, that becomes difficult to keep up, and so we're constantly. Every week is a battle to try and clear out the backlog, and so the idea of training more head and neck surgeons for the continent, we definitely see that at Kijabe and in the country. We need more. We definitely need a lot more people that can offer a good, safe surgery for head and neck cancer patients.
Thank you, Dr. Macharia. Dr. Koch, I am so in awe of the work that you've done, and thank you so much. I'm honored that you joined us. When you have exchanges, which I understand you do have some exchanges between Hopkins and Cameroon. What is the most valuable thing that an observer from another country can get from coming to a high-income setting? What do you think is the most valuable thing that they can glean?
Well, the fellows from our African training program have come to the U.S. for a month. And during that month, I think they get exposure to a multidisciplinary oncology team of the sort that we're all used to in the U.S., but is often not available. We saw the slides about how few places have radiation oncology, and that's starting to improve in the cities particularly, but isn't available for everybody. So I think to see how the pieces fit together and get an ideal sense of how that might be built in home country, what the nature of those collegial interactions could be, that's quite helpful. Obviously, the exposure to world-class surgical options, and there are things that people have read about but not seen, robotic surgery, laser surgery. A little exposure to that, I think, opens eyes. And it's my firm expectation that our African colleagues, especially again in the cities, will be catching up technically, during their career lifetime. Free flaps and maybe even robotic surgery will eventually be available in country. So being leaders, thought leaders for home country requires having your eyes opened. Of course, the fellows that go to Cape Town see that in a developed world setting there. Then I guess the last thing is an entrance into the societal networking that's available. I know Dr. Macharia and the others have gone to one of our national or international meetings and been able to meet people that maybe their textbook name is recognized, but now they can put a face to that and begin to interact. And that's, I think, quite beneficial to in both directions for us to build those collegial interactions.
You mentioned that you have, in 2017-18, you had 12 faculty members come to Cameroon to help out. What were the challenges for some of those faculty members? And how would you recommend future faculty to contribute to Cameroon's training?
Oh, I mean, I think anybody that's done a short-term visit internationally knows that the benefits outweigh the challenges for the vast majority of cases and for people. But the challenges are logistical, travel sorts of things. Different countries have different regulations. This is part of the problem we've had in this COVID year is a regulatory problem as well as a safety problem and regulatory problems at home. The travel is daunting. It takes 3 days to get to our site, and you're jet lagged when you get there. And about the time you've gotten used to the new time zone, you turn around and go back. The challenge of working in an environment without the safety and technological things that you're used to. Cameroon does, our program does have a CT scanner, but no MRI, certainly no PET scanning. So you learn, if you don't already have that capability, you learn how to do things the way that our professional fathers and grandfathers did, a lot of which is the same wisdom that we have now. It's just you have to recall to mind what you can learn from a good physical exam. You don't need to have image guidance on your CT scan to do sinus surgery if you know the three-dimensional inside of the nose, for example. So those things I think are stretching and of great benefit both to the faculty and to the residents who've been able to come. And I would say everybody has had a great experience if they take the plunge and go and do it.
Thank you. My observation likewise is the either trainee or U.S. high-income faculty member who's had the opportunity to contribute in that way, they actually come home and they're a much more thoughtful user of resources, which is desperately needed on the high-income country side. And likewise, the ability to make good, sound clinical judgment without all that high-tech stuff is a challenge to keep. And so that is one of the huge benefits. I see that we are just at the end of our time, and I must thank you again. I am so honored that all three of you agreed to give of your time and expertise. I learned so much, and I always do when I interact with you. And Dr. Macharia, I look forward to every month. The Head and Neck Tumor Board is unbelievably good and a learning experience. And I bring my residents into the room whenever I can. My Emory residents benefit tremendously from your presentation. So thank you. And
thank you so much.
Of course.